morning.
Welcome to the eighth webinar organized by the Latin American Federation of Endocrinology Feline. Today's event is titled Stages of Type 1 Diabetes and its Treatment. This lecture will be offered by Dr. Daniel Pérez and Dr. María Alejandra Ramos from Honduras. I am Dr. Dinora Rosales. I am an endocrinologist and current president of the Honduran Society of Endocrinology and Metabolism. And I greet you from the city of Tegucigalpa, also in Honduras. I will mention some relevant aspects of this session. We will keep our cameras and microphones off. We have simultaneous interpretation services in Spanish and English available on the globe icon, so you can have access to the language of your preference. The webinar will also be live streamed on our YouTube channel. It will also be at demand, both in this channel as well as in our webpage in Facebook and in the global education channel of the International Society of Endocrinology, who offers the endorsement to all our events. After the second conference, we will have a questions and answers session with both questions sent beforehand upon registration, as well as those you write with the chat tool on the bottom part of your screen, either in English or in Spanish. We will issue continuous attendance certifications that our team will verify at the end of the event. I will now introduce, with much pleasure, our first speaker, Dr. Daniel Pérez. Dr. Daniel Pérez is an endocrinologist from Honduras, graduated in the Hermanos Amejidas Hospital in La Habana, Cuba, former coordinator of the area of endocrinology of the Honduran Social Security Institute, former delegate of the Latin American Society for Diabetes for Honduras, and he is an active member and part of the board of directors of the Honduran Society of Endocrinology and Metabolism. He's also a member of the Latin American Association of Diabetes and the American Association of Clinical Endocrinologists. I yield the floor to him so he begins his presentation. Good morning. Today's topic is stages of type 1 diabetes and its treatment. We will talk about the type 1 diabetes management and treatment. We see, first of all, the agenda data of prevalence of diabetes. We will describe the pathophysiological mechanisms proposed. We will describe the methods available and in what population we do screening for type 1 diabetes. We will number the stages of type 1 diabetes and describe treatment options available and the research we've carried out in these stages. The world prevalence is very important. In 2022, we had around 9 million persons diagnosed with type 1 diabetes. Close to 2 million lived in low and middle income countries. 1.5 million were less than 22 years old, and around 5.5 million were between 20 and 59 years old. Around 1.6 million patients reached the age of 60 or more. In our region, we currently have around 500,000 persons living with type 1 diabetes between the ages of 20 to 59, and around 170,000 are less than 20 years old, and 125,000 live around 60 or more. This is a great health world problem, and we have specific data of the diabetes index for Hondurans that show that currently around 3,161 persons live with diabetes in Honduras, and that around 2,600 persons have died, people that should be living, but due to complications, they died before time. Around 49 years of life are lost for each person diagnosed with diabetes, and currently, 1 out of every 170 families is impacted for developing type 1 diabetes in Honduras. The prevalence and annual growth are around 7.1% per year in type 1 diabetes, being greater than type 2 diabetes with an annual growth of around 4.6%. The problem of prevention of diabetes is a historic one. In 1940 of the past century, Reginald Hayes and Charles Best wrote this editorial trying to raise awareness in the medical community to investigate a little bit more and to try to avoid type 1 diabetes, since they saw that the mortality was increased by this disease and that only with treatment they will not be able to resolve the problem. This is still so to date. The life expectation of patients that live with type 1 diabetes continues being low. If we see in Honduras, for example, the life expectation does not exceed 39 years. And the rest of Latin American countries, the vast majority, reaches the age of 54. Therefore, years of productive life continue to be lost. And this is not much different in the first world. For example, this cohort of Scotland that included close to 24,500 patients diagnosed with type 1 diabetes that had over 20 years, comparing this with people of the same age without diabetes, and they in follow up between 2008 and 2010, they found that male patients with type 1 diabetes had lost 11 years of life if compared to those that did not have diabetes, and women had lost 13 years of life if compared to those that did not have diabetes. So it is very important to realize that type 1 diabetes, if it's not well treated, leads to years of life loss. These are the stages of diabetes. In order to develop type 1 diabetes, there have to be a genetic risk that predisposes to its development. We'll see that the genetic predisposition is the initial and most important aspect. And we see, for example, that the risk of suffering type 1 diabetes in the general population without relatives that have type 1 diabetes is 1 in 300. However, if we have the risk in persons that have type 1 diabetes, it's 1 of every 20, 15-fold. So we see this is very important when predicting. We see that the son of mothers with diabetes is 1 in 50. The son of a father with diabetes is 1 in 15. The identical twin of a person with type 1 diabetes is 1 in 3. And the sibling, 1 in 20. Therefore, it's very important to test in all relatives of first and second degree type 1 diabetes and every person where we suspect that they have type 1 diabetes as per their clinical presentation. So the child of mothers or fathers with type 1 diabetes should be screened, and brothers and twins should also be screened. Among the genes that are most linked to genetic predisposition of type 1 diabetes, we see the genotype related to the highest risk is the heterozygote DR34. Around 30 to 50% of the risk of type 1 diabetes is linked to HLA localized in chromosome 6 with haplotypes DRB1, D3D1, DQB1, 02 and 01, D3 DQ2, DRB1 0401, DBQ 0302, which is DR4 DQ8. The non-HLA are genes that also have a lower contribution in developing type 1 diabetes. And for insulin gene, we have the cytotoxic lymphocyte gene or CTL type 4 and the gene of the tyrosine phosphatase protein PTPN22 and the gene for type 1 growth factor. We also see that it is very important that in order to develop type 1 diabetes, having a genetic risk, we have to activate the immune response and generate an autoimmune reaction towards the beta cell. Here we see that in the etiopathogenesis, there will be triggering environmental agents, amongst which we have chemicals, microbes, some foods, maternal breastfeeding, formulas, altered microbiome, and characteristics of the mother that will lead to changes in the genome or epigenome when interacting with diabetes, as was mentioned, that are related to type 1 diabetes. This will generate mutation in genes or epigenetic disruptions that trigger dysfunction in immune process, altering the normal immune function and triggering an autoimmunity against the beta cell. This will generate stress in the endoplasmic reticulum, significant stress in mitochondria, and an apoptosis of the beta cells that will reduce the production of insulin, generating hyperglycemia and therefore type 1 diabetes. Here we see many environmental determinants that have been invoked linked to developing type 1 diabetes. We will not mention them all. Only among microorganisms, we have viruses such as E. coli, Coxsackie, and SARS-CoV-2 that have been linked to type 1 diabetes. a change in microbiota towards an unfavorable microbiota with a reduction in lactobacillus and bifidobacteria that give a healthy immunity, and change to bacteroides and gram-negative endotoxins produce activation of autoimmunity. On the other hand, we've also seen a reduction in time of breastfeeding between the third and fourth month. Introducing cow milk or formula also activates autoimmunity. The mother's lifestyle, such as obesity, alcoholism, and smoking, will affect the autoimmunity in the newborn. We see that in order to develop type 1 diabetes, we have to activate this autoimmune system and have beta cells as a target organ. For that, we have to produce autoantibodies, and they were known since the 1970s. In 1974, Bataccio and collaborators discovered the anti-islet antibody, and later in 1982, its genetic structure was discovered by Bakiskov et al. In 1983, Palmer discovered the autoantibody for insulin, and later on, the rest of the autoantibodies were discovered progressively. In the pathogenesis of type 1 diabetes, first there has to be an activation of specific T cells against beta cells, developing autoantigens. Then there will be a presentation of these autoantigens to the beta cell that is activate and will interact with type 4 lymphocytes and CD8 lymphocytes in the dendritic cells. This contributes to exposure to this autoantigen, and they're formed in the beta cell, and the end it generates its damage. Here we see that after a viral infection on the right, there is an antiviral response with cytokines, chemokines, and interferons being generated that will give rise to cellular dysfunction, stress of the mitochondria, and increase in ROS and an increase in the production of new antigens. This presentation of antigens contributes to the activation of the beta cell that will generate antibodies that will increase furthermore this mitochondrial stress and in the endoplasmic reticulum. If in the presence of a genetic predisposition and after environmental factors, epigenetic changes in the beta and immune cells occur, all this will be the perfect storm that will trigger apoptosis, reduction in the production of insulin, increase in tissue inflammation with greater recruitment of immune cells, amongst which we have T lymphocytes, CD4, CD8, lymphocyte B, CD20, macrophages, C69, and many nuclear factors are produced that will generate inflammation, apoptosis, and maintain destruction of the beta cell. This has also been studied very well with viral infections. We know that viruses can kill the beta cell directly or trigger innate immune response that will activate the JAK-STAT pathway that will phosphorylate interferons. The interferons released in the innate response will be phosphorylated and translocated towards the nucleus. Once in the nucleus, it will generate a transduction of signals that will generate at the end changes in DNA that will contribute to damage in the beta cell and resistance to insulin. This reduces signaling and sensitivity to insulin and will reduce the capturing and use of glucose in parallel to the damage produced caused by stress in the beta cell. We have seen multiple markers that are determinants for this stress and cell death. The most important one is the proinsulin to peptide C ratio that is increased and is a marker and predictor of debuting with diabetes. It will be increased in all patients that have a debut with type 1 diabetes and those that have a high increase of antibodies that guarantees a rapid progression. Also, the increase of non-coded microRNAs is also observed in patients that debut with type 1 diabetes and in those that have an increase in antibodies upon diagnosis. We know that type 1 diabetes is associated with other autoimmune diseases, and the production of antibodies will be first against the beta cell, but afterwards, after the age of 2, there will be autoantibodies produced against the gut in the case of celiac disease and in the case of stomach cells with pernicious anemia. Afterwards, in adolescence and puberty, antibodies against the thyroid will appear causing Hashimoto thyroiditis and Graves' disease. After we see this, the immune response will be activated, generating stage 1. This is usually asymptomatic. Two or more antibodies are detected in more than two occasions, and there is an autoimmune attack against the beta cell. It is still functional, and usually the patient is asymptomatic. The risk in this stage for developing type 1 diabetes throughout lifetime is 100%. We'll see that the progression from this stage to stage 2 or 3 will depend on a series of factors. First, age, positivity of antibodies. The lower the age, the progression will be more rapid. The genetic pattern, if it's non-HLA, will be faster. The amount of antibodies detected. If it is greater, the progression is more rapid. Specificity and affinity of antibodies. The greater the affinity and specificity, the greater the progression. The titer of antibodies, the greater the titer, especially anti-insulin and IA2, the progression will be more rapid. And BMI, if it is increased, especially in Latinos less than 12 years of age, the progression will be faster towards stages 2 and 3. Here we see this study from Brinkley, published in Diabetology, how the progression behaves depending on having one single antibody or multiple antibodies being in stage 1 or progression to stages 3 to in 5 years. If we have one antibody, there will be a progression of 6%. If we have multiple antibodies in 5 years, the progression will be 22%. We know that having one single positive antibody is associated to progression in 50% in subjects. The progression of having one autoantibody to multiple usually occurs in 2 years, and there can be a reversion when we have one autoantibody, but where there are multiple ones, there's no reversion. We see that the progression to stage 1, from stage 1 to 3, when we have multiple antibodies, is 15 years in 85% of the subjects. Once we're in stage 1, we will progress to stage 2. Stage 2 is when the immune response has damaged the beta cell, affecting its function. In this stage, we have multiple positive antibodies in blood. The patient has dysglycemia or glucose intolerance. They're usually asymptomatic, but they can present mild symptoms. The risk at 5 years of type 1 diabetes can be 70%. It can reach 75%, and the lifetime risk is 100%. There is a marked cell infiltrating the beta cell with a high concentration of TCD20 lymphocytes generating insulitis. This predicts there will be a greater loss of beta cells in this stage. At the same time, the glucose tolerance curve, peptide C at 30 minutes at the peak of peptide C and the area under the curve is reduced. This predicts a more rapid progression. Peptide C is also reduced at the end of stage 2. When we have stage 2 with multiple antibodies and the tolerance to glucose is altered, over 70% progress to stage 3. Once in stage 3, we will have what we knew before as debut. Usually the patient is less than 35 years old, BMI less than 25, but it can be in greater than 35 and even in obese patients. The patient is symptomatic, very catabolic with fatigue, polyuria, polydipsia, polyfatigue, asthenia, blurred vision, fatigue. Peptide C tends to be low or absent. The values of glycemia are high. They can be above 360, between 40 to 60% debut with acute complications of diabetes and fundamentally with diabetic ketoacidosis. This hasn't changed much. If we analyze this study published in the Johnson Clinic in Boston in 1926, we see that back then the cause of mortality in patients less than 10 years old was diabetic coma or ketoacidosis. In less than 20, they had kidney disease. In less than 30, kidney disease and cardiovascular disease. Above 30, cardiovascular disease was predominant. In this study on the right, carried out in 2020 in Scotland using population from their healthcare database, in patients less than 30 years, ketoacidosis, here in gray, is the main cause of death. In those less than 40, we have cardiovascular disease plus the diabetic ketoacidosis, and in those less than 50, cardiovascular moves to the first place. Therefore, we need to reduce complications. We need to reduce mortality. It is very important to try to detect in stage 1 or in the genetic phase in order to try to detect genetic predictors to avoid that this patient reaches stages 1, 2, and not make a debut. Therefore, it is important to carry out programs that benefit this. Here we see how the different stages of evolution occur. In stage 1 up to stage 3, we need to minimize acute complications and chronic complications of these patients. From this point on, we will talk about management and treatment of type 1 diabetes by Dr. Alejandra Ramos. Good morning. Thank you very much, Dr. Daniel Pérez. I'm pleased to greet you from Quito, Ecuador. I'm Carla Garay. I'm an endocrinologist with a specialty in obesity. I studied in the Italian hospital in Buenos Aires and the São Paulo, Barcelona, with a degree awarded in the UVA of Parpaloro. Currently, I am head of the technical unit of endocrinology in the hospital's Carlos Andrade Marin and vice president of the Society of Clinical Nutritionists of Ecuador, honorary member of ACE. I am pleased to introduce our second speaker, Dr. María Alejandra Ramos. She's an internist and endocrinologist, coordinator of the transdisciplinary group of endocrine diseases of the school hospital, coordinator of the Integral Metabolism Center of Honduras Medical Center, Vice President of Honduran Association of Endocrinology and Metabolism. I remind you that at the end of the second conference, we will have a Q&A session coordinated by Dr. Dinora and myself. Please, Dr. Alejandra, the floor is yours. Good morning. Thank you, Dr. Carla Garay, for this kind introduction. Now I'll talk to you about the stages of type 1 diabetes and its treatment at the light of current evidence. We will begin in general, returning where we left off with Dr. Pérez. This classification of diabetes in 3 stages. Stage 1 is the preclinical phase, stage 2 with a very mild clinical presentation, and stage 3, what we're used to manage as type 1 diabetes with symptoms. In stage 1, the purpose of the treatment, any treatment intervention you'll see in this graph in red, is to stop autoimmunity, like was in stage 2. Starting stage 3, the current strategies for treatment seek not only to stop autoimmunity, but to protect beta cell and maintain euglycemia. In late stage 3, we need to add preventing long-term complications and acute complications in patients living with diabetes. How do we do this? Currently, for insulin replacement, we have some novel methods. We have replacement with basal bolus schemes. We have basal insulins like Glargine U300, Degludec, Glargine U100, Detamir, NPH, we have mixes, we have rapid insulins, glulicine, and Lispro, aspirin, regular, and ultra rapid like Lyumjev and Fiasp. It is important to understand that in addition to replacing with these pens in basal bolus schemes or using vials, we now have technology that has been incorporated with intelligent insulin pens that have a record of the dose and time the insulin was applied. We also have pumps with continuous glucose monitoring where the administration of insulin is suspended when there is hypoglycemia, and with the technology we have, they can predict not only hypoglycemia, but also hyperglycemias up to 5 hours. They calculate a ratio of the active carbohydrate and active insulin through algorithms to predict the dose of insulin the patient requires. We also have pumps that are partially automated hybrid methods with continuous glucose monitoring, where the patient has to introduce the data of intake of carbohydrates for adjustment, and the automated pumps with systems that have been proposed biohormonal glucagon insulin that is the future of pump management. It is important that to begin the management of patients in stage 1, I have to do a screening, as Dr. Perez explained. So we have a series of strategies for screening. We well know, like the trial net as the NDIA F1 or FRIDA. And what we did before is that once we screened the person and we found that the person had in glucose intolerance, we did glucose of 5, intake 0, 30, 60, 90, and 120. Now we're proposing that in this population of patients that are screened and are at risk because of antibodies, we only do a tolerance curve with a sample taken in 120 minutes. Why? This will be more cost effective and more acceptable for most patients. Just imagine they will be positive in time. Maybe the first one is negative, but if 5 takes are taken each year, the cost increases and it's difficult for patients. Australia undoubtedly is leading everything that has to do with screening of type 1 diabetes and research in prevention. They have a pilot project. It is a huge initiative, and they have partnerships where they're trying to identify children and adults that are at risk for type 1 diabetes to improve health outcomes and at some point prevent developing type 1 diabetes. How are they doing this? They participate in 6 different strategies. They have the India trial, trying to find the cause of type 1 diabetes. They have a national screening program for the general community. They have the type 1 screen that is for the relatives of patients that live with type 1 diabetes. They have the ADDN. This is a long-term follow-up of people that live with type 1 diabetes. They're also working in collaboration with immunotherapy. One of them is the TrialNet, and the TrialNet has a version for New Zealand and Australia, and this is a global version. The TrialNet is a cost-free study. It's a path for worldwide prevention and it's an organization, the trialnet.org, not profit. And the idea is to analyze first and second degree relatives of people living with diabetes using antibodies for screening and the possibility that these people that are diagnosed as positive with antibodies and that are at high risk can participate in the different trials that are being carried out in order to preserve the beta cell or avoid developing an aggressive autoimmunity that causes clinical diabetes and also monitoring progression. We know that the TrialNet and several of these screening studies have allowed an earlier diagnosis of type 1 diabetes. Why is this important? In these images, I show that when these trials have been done comparing the debut of diabetes in patients that were investigated when they were symptomatic, a great reduction in number of patients that will debut with a ketoacidosis occurs, and evidently morbidity and mortality is reduced of people that debut with diabetes because currently most people debut with ketoacidosis, which is life endangering. Not only that, the HbA1c level is lower, hence lower complications, a longer survival of beta cells at the long term, at least less steatotoxicity. This has been seen in this study of children diagnosed with diabetes. They're pre-symptomatic. Through a public health screening strategy, they found diabetes with a mild presentation, less aggressive. Here we compare the findings of the levels of HbA1c in the first chart, plasma fasting glucose, peptide C in the third one, and those that participate in the FR1DA or FRIDA, their HbA1c was lower than patients recently diagnosed that had a debut spontaneously in the MELI. And we can see the same in plasma glucose and a greater number of peptide C on diagnosis in patients that were screened versus those that had a clinical debut with diabetes. These prevention trials, what have they allowed us? They've allowed us to find a population that had not developed diabetes or that were in stage 2 where antibodies are positive, they had dysglycemia, and they were introduced to teplizumab. In 2019, there's the first publication of this monoclonal antibody that binds to CD3 antigen and target cells. It generates regulatory cytokines and regulatory T cells. They limit the action of the effector T cells and block immune response. This drug has been approved for first and second stage diabetes with family history of type 1 diabetes greater than 8 years old up to 45 years. They have to be in type 2, in stage 2, that is, have dysglycemia with positive antibodies in 2 occasions and an abnormal glucose tolerance test. Teplizumab, basically, it shuts off the immunity in the beta cell. We have this deactivation that is induced by the antigen when it binds to the CD3 cell. And what we can see is how the drug promotes the appearance of regulatory T cells. It's basically like a fire extinguisher of immunity and the inflammatory response that occurs with type 1 diabetes. The induction of these regulatory cells by teplizumab prevents the activation of CD4 lymphocytes T and CD8 cytotoxic factor. This induction of CD4 and FOXP3 plus T lymphocytes gives secretion of anti-inflammatory cytokines, growth factor type B, and interleukin 10, practically restoring the balance between the inflammatory and anti-inflammatory stimulus. At the end, it delays the appearance of type 1 diabetes, that is clinically, symptomatically, in patients that are at a high risk of suffering. In the first part of the study that was done up to 60 months, what they saw is that people that used teplizumab, there was a reduction in the risk of developing clinical diabetes. They were randomized in two arms. The treatment was for 14 continuous days. The tolerance test was done every 6 months, and the mean time to diagnosis with teplizumab was 48.4 months versus 24.4 months in the placebo arm. Afterwards, in November of 2022, the FDA approved, but well, one of the limitations is the cost. As you can see, it's $200,000, but it's the first treatment in 100 years that can alter the course of the disease, approved by the FDA. In the extension trial, what they did was review the same patients 12 months later. And in the treatment arm, we had patients with 59.6 months without developing diabetes versus 21.1 months in patients receiving placebo. Of the 13 subjects that were followed up to 60 months, that is 5 years, 10 were never diagnosed with diabetes. Of these, 8 were in the teplizumab group and 2 in the placebo group. But we have another tool. It is the use of the anti-thymocyte that preserves beta cells a bit more. It reduces HbA1c and increases the conventional regulation of T cells in patients that have recently diagnosed type 1 diabetes. So this is a clinical trial at 2 years led by Dr. Michael Haller in the University of Florida. The N was 89 patients, dose 2.5 milligrams per kilogram. What they saw is that patients that used anti-thymocyte globulin, there was a lower destruction of the beta cell with a better peptide C. You can see placebo in red and the doses of the anti-thymocyte globulin in green and blue, and how the amount of peptide C in time was higher throughout the different measurements with the dose of globulin versus placebo, and how glycated hemoglobin inversely is higher in the placebo group, as you can see on slide C, versus patient treated with globulin. So practically, it prolongs the half-life of the beta cell and the honeymoon period. We see these are initially diagnosed patients, less than 100 days of diagnosis, ages between 12 and 45, 2 days of treatment, 2 years of preservation of peptide C in type 1 diabetes, lower figures of H1C in the groups treated with both doses. We also have abatacept in patients of recent diagnosis of stage 1 of type 1 diabetes. This clinical trial was published in 2023. And here what we saw is a reduction in the loss of peptide C and the capacity of the beta cell. Once again, we observe that it takes longer for the patient to develop the complete dysfunction of the beta cell. We will have a larger area under the curve of peptide C produced in the treated group versus a non-treated group. Also, in the image of HbA1c, we can see how the group that was treated with abatacept has a lower HbA1c than the group treated with placebo. Why is this important? Where we have an extension, we see that eventually at 96 months, we will observe how the curves approach, but we had up to 84 months where we had a lower deficiency of peptide C. It prolongs the life of the beta cell and the time of the beginning of overt type 1 diabetes. There are many molecules in the pipeline. you can see there are many monoclonal antibodies, different immunomodulating therapies. The teplizumab trial is being run in patients below the age of 8. We have golimumab, and we wanted to show you these graphs where we can see the image of the different trials that I will share with you in a while. We also have the first drug that is cell therapy, approved for type 1 diabetes. This cell therapy has the commercial name of Latindra. It's allogenic cells of the pancreas islets are injected in patients that are unable to reach their A1C target because they have too many severe hypoglycemias that are life-threatening. So, with education, diabetes management, we have two clinical trials, one arm, 30 patients, type 1 diabetes, the patients with a loss of sensitivity with severe hypoglycemia. One and up to a maximum of 3 doses were applied. 21 of the 30 participants were insulin-free for 1 or more years. 11 of the participants did not require insulin in a period between 1 to 5 years, and 10 of the participants had not needed insulin in the past 5 years. 5 of the patients were not ever independent of insulin. That is the information we have of until its approval in June 2023. As I said, it's only indicated in type 1 diabetes with severe or very severe hypoglycemias that are life-threatening, that in patients that can't reach their A1C targets. We also have Vertex. Vertex is a research line. We have different pathways for administering it. We have VX880. These are cells that produce insulin. They're injected in the vena porta. We have VX264 that encapsulates a beta cell in a device that will not require immune suppression. And here we see in the next images the different immune modulators that are being studied. As I referenced, I recommend this book that speaks in general terms about type 1 diabetes, from therapies to diagnosis, the different antibodies. And you see how in the summary, it shows the different immune modulating therapies and how they allow a longer life of beta cells. This has been done with cytokines, immune modulators, and the different clinical trials. Take-home messages. Screening, like Dr. Daniel said, can save lives. We need to know the stages. It allows us to have a better control and less complications. And currently, definitely, we can change the natural history of type 1 diabetes. These are images of the club of patients with type 1 diabetes in our country, led by pediatric endocrinologists that undoubtedly are superheroes for the families of these people that live with diabetes. We thank you for your attention, and we're here for any questions you might have. Excellent presentations. Thank you very much. We'll now begin the round of questions. We have a question from Dr. Karen Pineda from Honduras. And she's asking, why can't we use Ozempic in type 1 diabetes? If you excuse me, Alejandra, I will respond to the question. In type 1 diabetic patients, they're insulopenic patients. They have deficiency in releasing insulin from the beta cell. The pathophysiology or the mechanism of action of GLP-1 analogs is to stimulate the release of insulin by the beta cell and to reduce the release of glucagon by the alpha cell. But we also know that these drugs have multiple benefits such as weight loss, reduction in hypertension, systemic inflammation, cardiovascular protection, and kidney protection. Therefore, the future use of GLP-1 analogs in these groups of patients might be valued. Currently, there are tests like trials like one that was published in 2022 that assess treatment with GLP-1 analogs and SGLT2s in type 1 diabetes, and it is observed that they offer benefits in reducing glycemia. There is a benefit of the reduction in the dose of insulin, but they can generate side effects. Therefore, this is still in investigation. There are trials that have used combinations of
Agarrando
GLP-1s
el
with
LP1 que es
liraglutide,
propiolutide,
with
con anticuerpos
anti-interleukin
antiproliferativos
21 antibodies,
silenciados
both of them,
para
to
tratar
try
de
to
evitar la
avoid the
progresión
progression of
de la
diabetes
diabetes de la
from
etapa
the
P
pre-stage
hacia el
until
estadio
stage
1.
1.
Y
And the
los
main
beneficios
benefit has
fundamentales ha
been
sido
the
reducir
reduction in
valores de la hemoglobina
HbA1c
glicosilada y
values
la
and
glucosa,
glycemia,
pero van
but
a preservar
they
un poco
preserve
mejor el
peptide
efectivo, o
C a
sea,
little bit better.
van a
They
preservar un poco más
preserve
las
beta
células beta,
cells
por
better.
tanto,
Therefore,
tienen
they
ciertos
have
beneficios
some
que
benefit,
todavía
but it's
estaban.
still being studied.
Por lo tanto, no podemos cerrar tratamientos cuando en
Therefore,
el futuro los
in the
análogos de
future,
insulina van a
these
tener
analogs
cierta
will have a
indicación en
certain
algunos aspectos
indication
en
for
el
type
diabetes
1
tipo 1,
diabetic
pero el
patients,
tratamiento de
but
base
the
sigue siendo el
baseline
tratamiento insulínico,
treatment
ya que son pacientes
is with
insulinopénicos.
insulin because they're insulinopenic. Excellent, Daniel.
Excelente, Daniel. También,
Dr. Garay.
doctora Garay.
Sí, voy a dar,
Good
buenos
morning.
días a
I'm
todos. Voy a
Dr.
dar,
Pilar
soy la
de la
doctora Pilar de la
Peña.
Peña. Voy a
I
dar
will start
lectura
reading
a
some of
una
the
de las
questions that were
preguntas que
sent
enviaron
in
en
the
el
chat.
chat. ¿Nos pueden, por favor, responder alguno de ustedes, quien
Any of
desee?
you who would wish to
Y
respond, you're most welcome. What are the
¿cuáles son los
positive
anticuerpos
antibodies
positivos en el
in stage
estage
1 and what
1 y
happens
qué
in
pasa con
anti-gamma?
antigap?
Any of
Muchas
you who
gracias,
would like
doctor,
to
si quiere
respond,
responder,
please.
por favor.
I'll
Hola, doctora
respond. Thank
Ramos,
you, Dr.
muchas gracias,
Pilar.
doctora Pilar.
As was explained
Como le
by Dr.
explicaba el
Pérez
doctor
in the
Pérez en la
presentation,
presentación, hay
there are different
diferentes
presentations of
presentaciones de los
antibodies.
anticuerpos,
So depending
entonces,
on the stage
dependiendo
of
de la
evolution, it
etapa de
can be that a
evolución, puede
patient
ser que un
has
paciente
one, two,
tenga
three,
uno,
or more
dos, tres o
positive
más anticuerpos
antibodies. But in
positivos.
general,
Pero en
most
general, la mayor
patients,
parte
the
de los
first
pacientes, el
antibody
primer
that's
anticuerpo a tener
positive
positivo es
is the
justamente el
anti-GAD.
antigal. Y por
That's
eso es
why
que es un
it's one that
anticuerpo
is
que se
preferred for
prefiere en
screening
tamizajes en
in
sitios
places
con recursos
where
limitados
resources
como
are
nuestros
limited, such
países,
as our countries,
porque la
because the
probabilidad del valor
positive
predictivo
predictive
positivo en
value
las
in a
poblaciones
population, such
como
as relatives
familiares
of
de
patients
pacientes
with
con diabetes
type
tipo 1 de
1,
primer grado,
that is
es
first
valioso.
degree
Se ofrece
relative,
un
is
estudio
valuable.
poblacional
If
en
you do a
población abierta, pues se
populational
puede
study and open
considerar esto
population,
como prueba
maybe
de
the
tamizaje
success as a
menos
screening
eficiente,
test is
¿verdad?
less
Pero en
efficient. But in a
población bien
well-chosen
escogida,
population
donde
where
hay
there's a high
riesgo de
risk of
positividad como
positivity,
familiares de primer
such
grado,
as first degree
antigal sería el primer
relatives,
anticuerpo, pero
anti-GAD would
tenemos
be ideal. But
anti-insulina,
we have anti-insulin,
anti-K2,
anti-K2,
y
and
entonces
we
podemos
can
hacer el
use the
resto de
rest
los
of the
anticuerpos.
antibodies as well. Thank you
Muchas
very much.
gracias. Muchas gracias, doctora.
Añadir algo
Can I
ahí de
add
lo que dijo la
something from what
doctora,
the doctor said?
que está excelentemente
She presented it in
planteado.
a very excellent manner.
Realmente se ha visto que
There
hay
are
dos tipos de
two
endotipos de
endotypes
diabetes
of
tipo
type
1.
1 diabetes. There's one
Hay un endotipo
endotype
que
that has
debuta
an
mucho
earlier
más
debut
temprano,
and
así que
with
debuta
higher
con picos
titers
más
of
elevados de
anti-insulin
anticuerpos
antibodies.
anti-insulina.
This type of
Este
patient
tipo de
will
pacientes
have
van a tener mucho más
more lymphocyte
neutrofilación
infiltrates,
linfocitaria, mucho más
more
insulitis, sobre todo a los
istylitis,
niveles más
that is
altos
inflammation of the
CD8 y
islets,
CD4.
and higher
Hay otro tipo
CD8
de
and
endotipo que se ha
CD4
considerado
titers.
todo
There's another
origen
endotype that has been
clinical,
considered
aparece el
where
paciente
the
debut
patient
a
that has a
13 años
debut that is
siempre, y
older
en
than
este
13
grupo de
years old.
pacientes
And in
el
this group of
anticuerpo
patients,
más
the
presente
antibody that is
es
more
el
present is
anti-GAD.
anti-GAD.
Este
This
tipo de
type of
pacientes va
patients
a
will
tener
have
una
a
mayor
greater
reserva de
reserve of
insulina, por
insulin
lo que
in
va a tener una
the
mejor
islets of the
liberación de
pancreas,
insulina y va a tener
greater
menos grado
or better
o
release of
nivel de
insulin,
infiltración
less
o
grade
menos
of
niveles de CD8 y
inflammation, and
CD4. Por
lower
tanto,
levels of
dependiendo de la
CD8, 6, and
presentación,
4. So depending
pudiera
on the
haber un
presentation,
predominio de un tipo
one
de
autoantibody or
anticuerpo
another
u
could
otro.
predominate.
Aunque,
But
como bien
like
explicaba la
Alejandra well
doctora,
said,
en la gran
in
mayoría
the
el
vast
antigal es
majority,
más
anti-GAD is
eficiente.
the more prevalent one.
Sí.
Thank you, Doctor.
Muchas gracias, doctor.
Dr.
Doctora, de momento
Dinora,
sí
would
quisiera
you like
leer
to
alguna de
read some
las
of the questions that
preguntas que
were
mandaron en
sent
anticipado, por favor,
beforehand?
para continuar con las del chat.
Here we
Aquí
have a
tenemos una
question
pregunta
sent
que
by
nos mandaron,
Dr.
doctora
Alejandro Magnani from
Magdalena.
Mexico. He
Nos
commented
comenta
a
un caso que
case
de un
of a
paciente de
34-year-old
34
patient
años que
diagnosed with
diagnosticado con
diabetes at the age
diabetes
of
a los
12
12 años, con
with
características
characteristics
de
of type
diabetes
2
tipo 2.
diabetes,
Era
obese,
obeso, sedentario y tomaba
sedentary,
comidas rápidas.
he
Él le
ate fast
dejó como
food,
diabetes tipo 1
and
desde aquel momento,
he,
¿verdad?
in the
Cualquiera de
past,
antes
everybody
se
thought
consideraba
everything was
diabetes tipo 1.
type 1
Pero era
diabetes because of the
importante,
age.
se podría
Would
realizar
we do tests
usted
for
pasar
type
a tipo
1
1 para
to
descartar
disregard
ya que tiene
since he
características
has
de diabetes tipo
characteristics of
2?
type 2 diabetes?
Ahí el
Here,
problema es
the
el
time is a
tiempo, ¿verdad?
problem.
Porque si
If
tiene
the
34
patient is
años y
34
se
years
metió
old
a los
now
12,
and
¿verdad?
his
Y ya estamos por
debut was
26
at
años de
12, so
diagnóstico,
he has over 20
25 de
years of
diagnóstico,
diagnosis,
entonces es
it's less
menos aún
likely
nuestra
to
antígeno es
find
positivos. Antigat puede estar positivo hasta
anti-get
15
positive
años después.
antibodies. They're positive
Sin
up to
embargo,
15 years.
pero
However, it
puede
would be
evolucionar
interesting to see
mucho.
the
Entonces
clinical
creo que
evolution. We
no
should
debemos
never
nunca
leave
dejar de
aside
lado
what is a
cuál es el
clinical
pronóstico
behavior of the
clínico de
disease.
la enfermedad,
And
y aunque hoy en
although
día pues
currently
la
with
precisión de
precision
verdad es que
medicine, we know that
aún
even in
se
type
tienen
2
otros tipos
diabetes, we
de
have different
superantes de tipos
subtypes,
y como muy bien
like
mencionaba Daniel, de la diabetes tipo 1 también.
Daniel mentioned.
Yo
I
pensaría que
would
si este
think
paciente
that if
fuera
this
tipo
was a
2
type 1
a estas alturas probablemente requeriría
diabetic
menos
patient,
insulina de
he
todas
would
formas
require
porque pues
insulin by
físicamente
now
tenemos
because
que
of
hacerlos, ¿no? Entonces,
uh,
el que use o no
the
use
time he's
insulina
had
pues
with
tampoco va a hacer la
diabetes.
diferencia.
The use
El
of
caso
not
es
of
definir el
insulin
tipo
wouldn't
de
make any
diabetes.
difference.
En un mundo
In an
ideal,
ideal
obviamente
world,
tenemos un
he
perfil
should have a
genético y
genetic profile
ver
to
qué
see if he
tipo
has
de genes se lo
predisposing
predisponen
genes
en cuanto a
with
los procesos de histocompatibilidad.
histocompatibility complexes. I think that
Y
there we
claro,
would
de
have
ahí
to
sería la historia
see
familiar,
the
¿no? Porque
family history and the
pero
clinical
estaría difícil
presentation.
desempatar la
It
población
doesn't
y se me ocurre
occur
ahorita
to me
Daniel, se
any
me ocurre
other way
otra forma de
of
desempatar qué
knowing
tipo de
what
diabetes
type of
tiene este
diabetes this
paciente.
patient has.
No,
I
estoy
totally
totalmente de
agree.
acuerdo. Un LADA que sería
One
la
thing would
opción de
be the
progresión más
option of slower
lenta
progression.
y que tal vez, pero son
And like you
pacientes con
said,
22
22
años y
years is a
bastante
long time.
tiempo,
To
hacerle el
do a
análisis
genetic
genético si se
profile, if we
pudiera,
could
me
measure
haría el
the
anti-GAD
anti-GAD
para
to
tratar
try to
de descartar
discard
un LADA de evolución
a lot of with
progresiva más
a
lenta, pero como muy bien dijiste,
lower
tienes toda la
progression,
razón,
of a slower progression. But
es
you're right when what
descartarse.
you mentioned.
Bien, voy a dar
Now
paso
I'll
ahora a
move
las
on
preguntas
to a
que
question from
quedaron
the
en el
chat.
chat.
Dr.
La doctora
Imperia
María
Brakovic,
Brakovic, que nos
that is
acompaña
accompanying
desde
us
España,
from
ella
Spain.
representa a
She
Venezuela.
represents Venezuela in
Esta
Filaen. She's
pregunta
asking, with the
es
use
cómo los
of pumps and
defensores han
sensors,
mejorado la
has
sobrevida
the
en estos
survival of these
pacientes.
patients
Es una
improved?
excelente pregunta
Excellent
y creo que es
question.
un
It's a
poco
bit
compleja de contestar
complex
por
to
la
respond because of the
heterogeneidad que se
heterogeneity of the use.
Sabemos
We
que
know
como
that in
países
countries
donde
where
más se
pumps and
utilizan o
sensors are
mayores
used the
sensores
most
son
are
países
countries
de
with
mayor
more resources,
recursos, donde
where
además hay
there are other structures
implementadas otras estructuras
implemented
que permiten
that
una mayor
allow
sobrevida a
greater
la
survival
diabetes. Entonces
for
sabemos
diabetes. There's a
Finlandia como
Finnish
ejemplo maravilloso
study,
donde se
fantastic,
prolongó
where
15
the life
la
expectation
expectativa
was
de vida
prolonged for
comparado a
15
hace
years
30 años en este
compared to 30
periodo de
years ago.
2021.
This
Sin
trial was
embargo, es bien
published
difícil ahí
in
determinar si
2021.
esa
However, we
prolongación
don't
está
know if
determinada por el
this
uso de la
is due
tecnología o
to
porque
technology
simplemente
or
los avances
simply
en el
management,
manejo y
the
control
strict
estricto de la
management
diabetes
and
y la
control of
accesibilidad
diabetes
al
and
tratamiento para
accessibility
estos
to
pacientes en los
treatment in
países.
those
En nuestra
countries. In our
región,
region,
pues
there are
creo que hay
countries that
países
are doing
que
things
están
very
haciéndolo
well.
muy bien.
Chile,
Chile, creo
by
que Chile
far,
por
are
mucho y
doing things very
Colombia
well, as well as Colombia. They have the
tiene que
merit
estar mucho
of
mejor en el
managing
manejo
type
de la
1
salud en
diabetes much
cuanto a
better in
proveerle a los pacientes,
ensuring
asegurarles
treatment
tratamientos
such as
como
these
estos,
to
¿verdad? De alta
patients.
efectividad.
Now, what
Ahora, lo
has
que sí
been
está
shown
demostrado y el
worldwide
mundo entero
is
es la
improvement
mejoración
in
en la
quality
calidad
of
de vida.
life.
¿Verdad?
So
Entonces,
there
sí
is a
hay
reduction in
excepciones, ¿verdad?
severe
Las hipoglucemias
hypoglycemias.
severas,
There is a
hay un
better
mejor
control,
control
less
y una
variability
variabilidad que
that
evidentemente
evidently
mejora la
improves
calidad
the
de vida.
quality of life. She
Ella
also
misma
asks,
pregunta
between
en el proceso
tocilizumab and
Sumar y
globally,
pregabalina, ¿cuál de los dos
which of the
protocolos
two
da mejores
protocols
resultados? Y los
gives better
felicita a los
results? And
dos
she
expositores.
congratulates both speakers.
Muchas gracias.
Thank you.
Pues la verdad
Both
que los dos
protocols are
protocolos son
different.
distintos,
There are
muchos son
different
para
types of
diferentes tipos de
patients.
pacientes. Este protocolo
Teplizumab
está
has been
actualmente
approved
aprobado
for
para
patients that are in
pacientes que
stage
están en
2
estadio 2
and
y la
anti-thymocyte
globulina en
globulin
este momento
approved
está
for
aprobada para pacientes que
stage
están en estadio
3
3.
patients. So
Entonces,
with respect
en
to
cuanto a efectividad,
effectiveness,
pues
it's a
es
bit
dado
complicated
por
because they're
cosas diferentes,
different.
son dos
Claro.
cosas distintas. Lo
With
que sí se puede con el
teplizumab,
teclizumab,
even
inclusive
in
en
the
la
extension
extensión, es que
trial,
sí se
is that up
logra
to
hasta
5 years
rumbo año
without developing
sin
stage
desarrollo
3
de
are
estadio
achieved.
3 y
And
con el
with
timosin, la
anti-thymocyte
globulina
globulin
antitimocito, lo que se logra es
allows
una
for a
prolongación, digamos, que le
progression of
llamamos
what we
un
call
año
the
hasta 2
honeymoon
años.
of up to 2 years.
Muchas
Thank you,
gracias.
doctor. Dr. Rosales.
Doctora Rosales.
Tenemos,
Here we have
tenemos
another
otra pregunta
question.
que
sent by Dr. Ana Mejia from Colombia. In the approach to young adults, where the diagnosis of diabetes is in doubt, if it's type 1 or 2, that is, In the context of the focus on differentiating between type 1 and 2, what elements are necessary for diagnostic support and management?
Bueno,
Well, from a
desde
clinical
el punto de vista
standpoint,
clínico,
the
la
age of
edad de enfermedad
onset
generalmente
in
la
most
mayoría de
type 1
pacientes
diabetic
diabéticos
patients,
tipo
they
1
will debut
van a debutar
in an
por el
age
peso
less
corporal.
than 25
Segundo, el
years,
peso corporal
according to the
es un
body
factor.
weight,
Lo
although we
sabemos
know
que los
there are
edades
patients
pacientes con
that are
sobrepeso y
overweight or
obesidad,
obese.
la gran
The vast
mayoría pues
majority
van a
will
tener
have a
un peso de
BMI
masa
that is
corporal
normal or low.
normal o bajo.
Clinical
La clínica,
presentation, you saw that
sabemos que
between
entre el
40 to
40 y el
60% can
60% puede
debut
debutar
with
con
diabetic
cetoacidosis metabólica.
ketoacidosis. The
El cuadro
clinical
clínico es mucho más
presentation
marcado.
is more significant. The
La
presence
presencia
of
de resistencia a la
resistance to
insulina, niveles
insulin,
altos de insulina, hablaría más de un diabético
high
tipo
insulin.
2,
We'll talk
y la
about type 2
insulinopenia
diabetes and
sería un aspecto
insulinopenia
C
measured by
con
peptide
valores por
C
debajo
with
de 5
values
mililitros
below
nanogramos por mililitro,
0.33 nanograms
hablaría
per
más de un
milliliter
diabetes tipo
would
1.
speak of type 1
También
diabetes.
la
Also, the presence
presencia de
of
los anticuerpos,
antibodies.
como
As
ya
we
hemos
have said,
explicado,
if we
que
can
podemos
do that,
realizar, los
antibodies will be
anticuerpos
the
van a ser
main
marcador
marker
fundamental
in type
en
1
el
diabetic
diabético tipo
patients.
1
If we
y
can do
podemos
genetic
realizar los estudios
trials,
genéticos
the
de la
association
asociación
with a link of the
por ejemplo,
heterozygous
estereotipo
DR3, DR4
DR3 de reparto
gene
en la
in
diabetes
type
tipo
1
1,
diabetes
nos
would
descartaría. Pero sobre todo
give us
la clínica de
the
aparición,
answer.
la edad
But
de
the
comienzo,
clinical presentation, age of
realmente
onset, body
las
weight,
características típicas
typical
de resistencia a la
characteristics
insulina a
of
través
insulin
del efecto
resistance in type
Gaussian, todo
2
lo que es la
diabetes,
criologénesis en todos los cuadros
acanthosis
típicos del
nigris,
diabético tipo 2,
nigrans,
pero
and the
realmente en
clinical
ocasiones para poder
presentation that is
diferenciar
typical.
bien entre
But
una
to
y otra,
differentiate
tenemos
between
que
type
ir a
1
los
and type
estudios
2 diabetes,
de
we would
detección
have
de
to
anticuerpos y a los
do
estudios genéticos. No
measurements
en
of
todas las
antibodies and
poblaciones
genetic tests.
ni en todos los
It's not
países lo
possible to
podemos
do this
hacer,
in all
pero ya
populations or
sabemos
countries, but
que
we know
todos
that
estos
all
programas
these
son
programs, such as a
actualmente
trial net,
son
are
abiertos,
open.
podemos entrar
We
a sus
can log
páginas
into
y
their web
podemos
pages.
valorar si
We
podemos
can assess if we
pertenecer
can
al
belong to
programa
the program,
y
and
ellos
they
se
would be in
encargarían de
charge
realizar
of
todo
carrying
lo que
out the
ustedes
study.
son. Por lo tanto, eso
So along general
indudablemente
lines, that would
es
be
la forma
the
más
easiest way of
fácil de
differentiating
diferenciar tipo 1 y
type
tipo
1 and
2. No
type
sé si
2.
Alejandra quiere añadir algo más.
Y
Uh,
tal vez un consejo
would you like to
práctico.
add anything else?
En
Well, a
Honduras, la verdad, han
practical
mejorado los
advice. In
precios de los
Honduras, the
anticuerpos.
price of
Antes era
antibodies
algo
has
muy, muy
improved.
costoso.
Before it was
Y
very
hoy en día
expensive,
un
and nowadays
anticuerpo
an
puede costar
antibody
alrededor
can
de unos
cost around
$150.
$150, even
Entonces, o
up to
incluso hasta
$125,
$125,
which
que
is
es
more
ya un poco
accessible.
más accesible.
So
Entonces,
we
uno podría
could
empezar por hacer un
start
anti-GAD.
by doing an
La otra cosa
anti-GAD.
es que
And also
JDRF,
JDRS, which is
que es
the fund
el fondo
for
de
research for
investigación
juvenile
preventiva
diabetes,
juvenil,
as a
tiene un
project
proyecto
where
donde se
we
puede
can
enviar
send through
a través de
chromatography
cromatografía
a
una
blood
muestra
sample,
de
and
sangre
they
y ellos
run
corren
the
ensayos
assay
porque
for
unas son transportadoras
$150,
también
and
y ahí
they
se corren los
run the
test
main
anticuerpos
pre-antibodies.
intervales. Entonces
So
es
we would
entrar en
need
contacto
to
con
get in
estas
contact with
asociaciones,
these
¿verdad? Y
associations
ver
to
cómo se
run
están
these
corriendo
studies.
los
It's
estudios, porque
sent
eso se
by
manda por correo.
regular
Por eso
mail in an
utilizan un
envelope.
sobre, o
It's
sea, es
rather
bastante
simple.
sencillo.
There's a very
Bien,
valid
comentario muy
comment in the
válido al
chat
aprovechar
that
que se
mentions
menciona
that they're
los
not
nombres.
very
Queda muy
clear
claro aquí
who
el
you
por
ask
qué anticuerpos,
antibodies
porque estudios
for, because
genéticos
genetic
y por
tests
ejemplo
are of a
el
difficult
su
access.
comentario que manda la doctora Alejandra
Dr. Alejandra
Bueno,
Ortiz asks that
pues se
question.
le pide
We're asking
anticuerpos y en este momento
antibodies
la
to
indicación es familiares
first
de primer
degree
grado,
relatives. And
¿verdad?
TrialNet, for example,
TrialNet, por ejemplo,
offers
ofrece estudios en
uh,
familiares de primer grado de forma gratuita hasta
studies
los
to
18
families in the
años.
first degree
Y
for
se
free up to
establecen en
18
familias
years,
donde hay
and
otros
in
casos, digamos,
families
por
where
ejemplo, en
there's
casos
not only
individuales
one
de más de dos
index
casos, se
case,
puede hacer
but
hasta
more.
familiares de
In
segundo
the
grado.
second degree, you can also
Entonces,
do it. Who would
¿quién
be the
serían los
first?
primeros? Pues
Well,
los de
people
alrededor de
that
la casa,
are in
los
your
familiares
household,
y hermanos
parents,
de
and
pacientes viviendo con
siblings
diabetes tipo
of
1.
people living with type 1
Pues
diabetes.
en
In
el
the
caso
risk
de
score,
que
those that have
más
more
del
than
veinticinco por
25%,
ciento
up to
hasta un
70% are
60% son
sons
hijos o
of mothers
familiares
with type 1
con diabetes
diabetes,
tipo 1,
brothers, twins
hermanos gemelos
of
de
a type 1
pacientes con
diabetic
diabetes tipo
patient,
1 o
siblings with the
hermanos o
same
el mismo
genotype of a
genotipo con
type 1
pacientes
diabetic
diabéticos
patient.
tipo 1
And like
y como
Alejandra
muy bien
very well
dijo
said,
Alejandra, familia,
those that have
pacientes que tienen
multiple
múltiples familiares con
relatives with
diabetes
type 1
tipo 1,
diabetes, that
eso
increases the
eleva el
risk.
riesgo que
That
puede
can be
llegar
up
hasta
to
un
70% of
40% de
likelihood for
probabilidad de
the
desarrollar
development
diabetes
type
tipo
1
1.
diabetes.
Esos
These
tendrían
would
que
have to
ser
be screened.
Muchas gracias. Doctora
Entre
Rosales,
las
no sé, perdón.
Dr. Rosales, among the
entre las
questions,
preguntas también nos mandan
part of
algo de lo que
what we've
están
been
hablando
commenting
en ese
right
momento,
now,
como
uh,
puntualizar, porque
the
nos
question
preguntan
would
que
be, what
cuál
is
es el
the gold
estándar
standard
de oro que
for
se han hecho
diagnosing
estudios de alergia.
diabetes?
Lo
It's
pusieron
just
de manera
a general
general,
comment,
pero
but if we could hear from you.
Bueno,
Go ahead, please.
dele, dale, dale,
No,
dele.
no, DLC.
Well,
Bueno, la
diabetes
diabetes
is
es
a
un síndrome
multifactorial
congénito
and heterogeneous
multifactorial y las
syndrome,
cuestiones de
and the
diagnóstico
ADA's
ya están
diagnostic
muy claras.
criteria are very clear.
Realmente,
If we
si
see the
usted me ve, mi evolución
pathophysiological evolution,
fisiopatológica,
we could
si
think
diera
that
pensar
the
que el
glucose
test de
tolerance
tolerancia a la
test
glucosa
would
es el que
predict
predice más
earlier
temprano aquel diagnóstico
diabetic
y se
patients because it
detecta los
detects
niveles elevados de azúcar
post-charge
que
high levels. That is the
progresivamente
first thing
se
that
va a
will be
elevar en el
increased
desarrollo de la diabetes.
during the
Pero también
development by
sabemos
diabetes,
que una
but we
prueba
know
mucho
that
más
it's a
costosa y una
costlier
serie
test.
de
There are a series
requisitos
of
que
principles we have to
seguir
comply
que
with.
es mucho más
It's very stringent
estricta para la
for carrying
realización
it
en el
out in a
paciente
patient, and
y
this
esto
is a
es
bit more
un poco más
complicated.
complicado. Pero los
But
criterios de diabetes están bien claros.
criteria for
Hemoglobina
diabetes are
glicosilada
clear.
por encima de
HbA1c above
6.5,
6.5.
glucemia en ayunas en 2 ocasiones
Fasting
continuas
glycemia more than 2
sin
occasions of
mililitro,
126.
glucemia postcarga, test
Post-carb
de tolerancia a la glucosa por
glycemia
encima de 200 miligramos por decilitro
in a
y la
glucose tolerant
presencia
test
de
above
glucólidos
200
basados
and
por
a
encima
random
de 200
glycemia
miligramos por decilitro
above
en
200
combinación con
plus
síntomas clínicos.
clinical symptoms.
Por lo
Therefore,
tanto,
we
no
cannot
podemos
say
decir que
that
hay un
there is one
estándar por
standard that is
encima de
better than
otro.
the other. We
Generalmente
know
sabemos que
that
la hemoglobina
HbA1c
glicosilada
can have
tiene
aspects
aspectos que
that can be
pueden
modified,
modificarse, que tienen que ser la hemoglobina
standardized
glicosilada estandarizada
HbA1c, and each one of
y
them
cada uno de ellos nos puede
offers a
dar
benefit.
un
We're
beneficio.
very
Y tenemos
clear
bien
that
claro
these
que estos
are
son los
aspects
aspectos
for
para
diagnosing
diagnosticar
diabetes.
diabetes.
Thank you.
Muchas gracias. Bueno, hay una pregunta
Well,
aquí
there's
que
a
yo creo
question
que también se
here
han cuestionado en algunas
that
situaciones y
has
es, bueno, en
arisen
primer
quite
lugar,
often.
felicita
First,
y ¿cuál es
congratulations.
su
And
postura
the question would be,
en la utilización de glifosinas
what is
en
your
pacientes
stance in the
diabéticos
use
tipo
of
1?
glyphosines in type 1
Ahí sí hay
diabetes?
evidencia
We do have
al
evidence
respecto.
in
La
the use of
hipertensión sí
glyphosine.
está
It's been approved.
aprobada y la verdad es que creo que
Off-label, they're
objetos
used
se
a
utilizan
lot.
mucho.
Sí,
I think that
Creo
one of the
que una de las
limitations
limitantes
initially
en
was a
inicio fue ese
trial with
estudio
an
con el
increase
aumento de los
of
casos de
cases of
ketoacidosis que nos
ketoacidosis
asustó a
that
todos, que
scared
yo
us
ya estaba
all.
lista, la doctora Cristi Sierra y yo estábamos
We
listas
were
para
ready
lanzar un
to
ensayo
launch a
clínico
trial
posterior
in
y
our
ay, se nos
hospital,
corrió y
and
nos
the
detuvimos un poco,
publication
pero
was
poquito a poco
launched,
fuimos
and
perdiendo
we didn't do
fear,
it.
los decidimos
But we
retomar.
gradually
Pero
lost fear, and we've been using it
fundamentalmente yo creo y
off-label.
en base a una
Eventually, there will
forma
be a way
de
to
poder
measure
medir
ketones in
escenas en
blood that
sangre
is
más
easier,
fácil,
because
porque esa es
that's
la
the
limitación
largest
realmente
limitation. To
grande,
wait
pero
until
esperar hasta que
the
el presentara
patient has
síntomas no
ketones in
creo que
urine
sea un
is a
poco
bit
tarde.
late.
Entonces, si
If we could
pudiéramos
measure
tener una forma de medir
ketones,
cetonas,
we have
ya hay
ketones for
sensores para
sensors
cetonas,
available.
entonces de repente
So in
en los
patients such as
pacientes como
these,
estos yo sería
I
partidaria
would
de ponerle el sensor de
vouch
cetonas al
for
iniciárselo, ¿verdad? Que duran
putting
14 días, sería la
a
forma
sensor for
correcta de hacerlo.
ketones. That would be the
Y
correct way.
muchos
And in a
niños muy
well-educated
educados,
patient that
pero que
understands
entiende
that in
que en
stress
situaciones de estrés sus
situations,
requerimientos de
their
insulina aumentan, a
insulin
la
requirements
glucosa no
increase, although
aumente,
the
porque
glucose
ahí es donde
doesn't
se da el
increase,
problema.
which
Yo
is where the
creería que el
problem is.
problema
I don't think there would be any
se
problem. We could use them
utilizan off-label,
off-label.
se
They
van a
will
seguir
be
utilizando.
continuously
No sé si
used
vamos a ver un
off-label. I
desarrollo
don't know if we will
clínico
see a
grande
big
con una
clinical trial
población
with a
importante,
significant
con una de las
population of one
glifosinas
of the
más usadas,
glyphosines
porque no
that
tenemos
are
nosotras
used
en nuestros países,
the most
pero
in our countries. But
creo que va a ser más
it,
bien
I think, will
evidencia de
be
mundo real la que vamos
um,
a trasladar a
real
la
world
ciencia y que
evidence
los va a
that
hacer llegar a las
will
guías ahí en algunos
probably
humanos.
lead the way to
muchas gracias.
the guidelines.
Tenemos aquí una
We have a very
pregunta muy
specific
puntual,
question here.
¿verdad?
The
Que es
use of
el uso de antidiabéticos en
non-insulinic drug in the
supervisores en
initial
etapas
stages of
iniciales de
type
la
1
diabetes tipo
diabetes.
1, en qué casos iniciarlos
When to
y
begin
cuándo
them and when to
suspenderlos.
suspend them. They're not
No están
indicated.
indicados.
Type 1
La diabetes
diabetes
tipo 1
is an
es una enfermedad
insulin-panic
etiopénica,
disease.
no
There's no
tenemos indicación.
indication.
Incluso
And
en
in
algunos de
some
los estudios que
trials
se
that
hicieron al
were done
inicio,
initially
la
with
idea era
sulfonylureas,
el
we saw
empeoramiento,
worsening
¿verdad? Porque genera un
because
agotamiento mucho más rápido
there's an
de la duración de
exhaustion
la
of
vida
the
y
beta
no está
cell. They're not
indicado.
indicated
Realmente
to use
utilizar
oral
drogas
drugs
orales
in type
para
1
la diabetes
diabetes.
tipo 1 ya
We
vimos
saw the
ese es el
SGLT2
enfoque que
inhibitors,
acaba de
as
hablar
Alejandra mentioned,
Alejandra, que sí
that
hay
there are
estudios
real-world
monitoreados
trials with a
con
certain
ciertos
benefit
beneficios en
on
hemoglobina glicosilada,
HbA1c,
reducción de
weight
peso
reduction in
relativo a
type
diabetes
1
tipo
diabetic
1 que
patients that were
tenían
overweight,
sobrepeso,
but there
pero
was
todavía
also an
había un
increase in
incremento de cetoacidosis diabética que morían
ketoacidosis in the patients
pacientes
enrolled in
con
this
ese estudio
real-world
recientemente
trial
publicado
published in
en
2022.
2022.
Therefore, You should try to avoid it. In the case of sotagliflozin, it's been approved, but we need to give more time. We need to treat and treat with insulins.
Excelente. Y
Excellent.
además del
And
tiempo, maravillosas las
because of
ponencias.
time
A nombre de
constrictions, we would
María
like to
agradecemos a
thank
nuestros
our
expertos conferencistas,
excellent
a todos ustedes
speakers
por haber estado
on behalf of
presentes
Elaine, to all of you
y
for being
por haber
present, for
enviado
having
sus
sent those
interesantes
interesting
preguntas.
questions. And I
Doy la
yield the
palabra
floor
a la
to
doctora Garay por
Dr.
un
Garay to
mensaje para
share a
nosotros.
message with us. We would like to invite you to our next event, September 21st, a Saturday, where Peru and Colombia will participate with obesity, surgical, and medical treatment. So we hope to see you. Excellent weekend. See
Nos
you.
vemos. Mucho
Thank you.
gusto. Muchas
Hasta
gracias.
Muchas
luego,
gracias.
gracias.
Have a
Buen día.
nice
Gracias.
weekend.
Excelente, gracias.